continuing with the information on anti-anginals and drugs to dilate the veins and arteries in the periphery, you see some interactions that you have to be careful with. Nitrates can increase the effects of drugs like atropine, which, if you remember, atropine is a anticholinergic drug. It can also increase the effects of tricyclic antidepressants. It can decrease the effects of drugs that act like acetylcholine. So if it's a parasympathetic agonist, it can decrease the effect of that. You don't want to take nitrates with a drug called prazosin. That's one of your previously mentioned antihypertensive drugs. You want to avoid that. Never, ever, ever take meds for erectile dysfunction with nitrates. If you are taking nitroglycerin and Viagra, you should keep 24 hours apart. So if a person starts having chest pain and they know that they've taken Viagra in the last 24 hours, it's best to just go to the hospital. Don't take that nitroglycerin. Chronic nitro users just avoid erectile dysfunction meds altogether. There is a particular danger. Sometimes you see somebody who's on nitroglycerin and they go for a romantic weekend away. They drink a little alcohol, they're in the hot tub, all of those are vasodilators, and then they take some erectile dysfunction meds. And instead of having a romantic evening, they basically have a complete collapse of the cardiovascular system. So they kind of have the opposite result that they wanted, and people have died because of this. The blood pressure gets so low and the person goes into cardiovascular collapse, and it's a very emergent situation. For peripheral vasodilators, if you use them with antihypertensive and alcohol, once again, you're going to get that strong vasodilation, can be very dangerous. Make sure you read that box on page 148 so that you know how to take the nitrates for angina. Like I said, you can take a total of 3 doses. Call EMS, don't drive yourself. If the person does not take a regular aspirin for cardiac issues, they should chew and swallow 1 regular aspirin if they haven't already had one that day. I did include a link from last year where they talked about aspirin and heart attacks. The most recent school of thought on aspirin and heart attacks is that people who don't otherwise have any risk factors should not take a daily aspirin. It used to be as soon as somebody hit the age of 50, it was kind of recommended that they take a low-dose aspirin to prevent blood clotting that could lead to MIs, and now they're saying if you don't have any risk factors or any problems, they're recommending that you don't routinely take an aspirin. So that kind of changes every year or so, but it can help to prevent any further clotting if, while you're waiting for the ambulance, if you chew an aspirin, you don't want a solid aspirin that is not going to break down in the stomach in time. Remember, to save the heart, the body is going to initiate the sympathetic neurotransmitters, and it's going to shunt blood away from the GI tract into the heart, into the brain. And so you'd have an aspirin just sort of sitting there in the stomach, not doing anything. Whereas if you swallow it, it's dissolved and it can be absorbed more easily into the GI tract. Here is a picture. Once again, you can't see it so clearly on my phone, but you can look at the slide close up when you're listening to the lectures, and you see what it looks like when a person develops peripheral vascular disease. The lumen of the vein narrows as plaque tightens things up, and then clots can form. And we've all, if you work in a facility, we've all seen the patients who have a lack of oxygenated blood to their lower extremities. You'll see those blue and purple feet and lower legs. And there's only so much that the peripheral vasodilators can help. All right, we will go on and talk about drugs for cardiac dysrhythmias. Remember, as I said, the heart is an electrical organ, so it responds to chemical messengers and it sends messages that tell the heart when to beat, how fast to beat, how often to beat, and that's the heart rhythm. And so we start talking about those meds on page 149. Now, we don't get deeply into meds for cardiac dysrhythmia because usually LPNs are not working in a cardiac area. If you go on to RN school, they're going to teach this far more in depth. But you want to recognize some of the drugs that patients take PO for dysrhythmias. So on pages 151 to 153 in your book, you see tables of antidysrhythmics, and there are basically 4 classes. The cause of the dysrhythmia, what is going on with the heart itself, are going to determine which drug is going to work best for that particular person. And so you see we have class 1, 2, 3, and 4 drugs, some of which we've talked about before. They're going to be familiar, and others that are not as familiar and maybe have not come up when we've discussed previous cardiac issues.